All right, so we shall get started. So thank you all so much for joining us this evening. So for our AGA Career Development Workshop tonight, we are very excited to have Dr. Carol Burke to present on work-life balance and how to spot and address burnout in GI. And so Dr. Burke is a member of the Department of Gastroenterology and Hepatology at the Cleveland Clinic and section head of the colorectal polyposis in the Sanford R. Weiss Center for Hereditary Colorectal Neoplasia. She is internationally known for her expertise in inherited colon cancer syndromes and colorectal cancer prevention. Dr. Burke has been awarded funding through the NIH, the USDA, the American College of Gastroenterology, industry, and many others. She's an active member of the American College of Gastroenterology and the American Society for Gastrointestinal Endoscopy, and is currently on the board of trustees for the American College of Gastroenterology. And so we're very excited to have her. If you have any questions for Dr. Burke throughout her talk, please put them either in the chat or in the Q&A, and I will address them as we go along or at the end of the talk. So with that, Dr. Burke, please take it away.
Thank you much. So, Holly, I really appreciate the invitation and the warm welcome. And I'm happy to share both my successes, but also some of my challenges to create opportunities for you guys so you can learn from people who have made some mistakes in their career before. There's a lot of intersectionality between career development and work-life balance. And I know this evening we'll talk mostly about work-life balance, but I also wanted to bring up some important points about enhancing your professional satisfaction in the workplace that can mitigate burnout and tackle some of the other things that oftentimes we're subjected to in the course of medical training, in our practice, and in the workplace, including microaggression and the imposter syndrome. Originally, I told Holly that I'm not going to use any slides. We'll just leave it open for a free-flowing discussion. But then as I thought about certain topics that I thought would be important for you guys to recognize, I did put some slides together, but I'm happy to slow things down, stop the slide. So it's all about you. And I hope that you can have a fruitful discussion through the chat. And I'm really happy to answer any questions. My disclosures include the following, and I guess I will also want to disclose that I'm not an expert in work-life balance. As I told Holly, my husband said, "We're eating dinner, where are you going?" And I said, "I have a lecture at 8 o'clock. He said, "But we're eating dinner." I said, "It's on work-life balance, honey, get over it." So my personal disclosures is that I may not be an expert in this, but I am a work in progress. So what is work-life balance? And it really is the ability for you to create the lifestyle to achieve the goals and enjoy your life, which includes at work, with your family and friends, things that you like to do for yourself. And hopefully when you are able to get this balance, then you'll have pride and satisfaction, happiness, love, celebration, well-being, and health. It's important to recognize, and I've been in practice 30 years, many of you might be in training or just starting in practice, that your work-life balance may alter over the course of a career. Young children at home, a dependent spouse that may be ill, alterations in the amount of time you spend at work. So work-life balance may look like one thing today, and it may look like something different tomorrow, 5 years, 10 years, or 20 years. I think the important point about creating work-life balance is if you don't have it, it can affect your health, it can create burnout in the workplace, and it can severely affect your relationships with family and friends. So let's start with talking about burnout. And there are some scientific definitions. And if you look at most of the literature, and a lot of it started with Tate Shanafelt, who had been at the Mayo Clinic and now is the, I guess, the wellness officer at Stanford. It's a work-related syndrome that's characterized by low sense of personal accomplishment, emotional exhaustion, and depersonalization, where, it's another potentially IBS patient and you think, oh no, it's Mr. So-and-so. I'm not sure I could even listen to him today. But it's that depersonalization where you're cynical, you don't have compassion for your patients. And in fact, there is a burnout scale, the Maslach burnout scale, which can be used to measure this. And there's some other shorter questionnaires that can be used. So I got interested in this topic when I was president of the American College of Gastroenterology in 2017. And Holly must have had an old bio for me because I'm no longer on the board, but I still am on, the awards committee and active in the ACG as well as the AGA and ASGE. But this was an interesting study that Tate had published looking at a group of surgeons in 2012. And I bring this slide up because they looked at factors associated with the surgeon's high quality of life. They also looked at factors that were associated with burnout, and there is a relationship between these. And what they showed is that individuals that were compliant with the CDC activity guidelines had a 20% increase in quality of life compared to those that were not compliant. Individuals that found meaning in their work took a positive outlook to life. They incorporated work-life balance, focused on what was important to them in their life, whether that's in the career or at home and in both. Individuals who take vacation, 40% improvement in quality of life. And we have some data, and in my department, I know that I have colleagues that let their vacation days go. People that engage in recreation and hobbies. And when you look at the two last factors in those rows there, regular meeting with a psychologist and individuals looking forward to retirement were associated with a lower quality of life. And so which came first, the chicken or the egg? Maybe they have psychiatric issues or they had burnout that related to those factors being a negative association with high quality of life. So in terms of career development, I know this is the end of your series, but it's really important for you to take stock and set priorities for what you want to achieve, what your goals are. So both in the personal realm and in the professional realm. And I would say that the goals for the 4 Ps are, when you're looking at your career, is what type of practice would you be looking for if you're not in practice, or if you're currently in practice, is that meeting your goals? Looking for a career or in practice, what are the perks? Because sometimes, being in a practice is like a marriage. And if all of your partners don't care about work-life balance, all they want to do is, do many procedures and generate RVUs, and you're fighting to get into the endoscopy suite, and they're looking at you like, why? Where is your productivity? They're all pushing. So you really need to think about, what within your practice could you negotiate on to make sure that your goals are met, and making sure that when you're joining a practice or looking at practices that you understand what your partner's focus is and maybe what the strategic plan for the group is. Certainly you want to take a look at pay. And for me, I've never been a full-time gastroenterologist. When I was in my GI fellowship training, I was pregnant with twins. I had no family in Northeastern Ohio, where I'm from, and my husband's Lebanese, and he didn't have any family in the United States. And so for me, it was more important to spend the time, 50% being home with my children. And eventually I got up to 80%. And then last year back down to 60%, because I want to enjoy other aspects of my life. And we can talk about, well, how do you do part-time work? And then again, as I said, your partners. So your partners are really your partners, your spouses at work, because you probably spend more time at work with your colleagues than you do with your spouse or family at home. Okay, so this is data that we are finally hoping to publish. It was submitted to a journal recently. Joe Anderson, Jill Gatos, Amy Oxentenko, Chris Sorowitz, and I looked at, and some of the other members from the ACG looked at our national survey data and practice factors in the national survey. And the reason that I bring up practice factors is that I think one of the attendees asked a question about, well, how many patients am I expected, to see in a day? And so we were interested in this very large survey that looked at the Maslach burnout inventory, as well as, what the practice looked like 4 gastroenterologists in America before COVID. And what you could see is that the majority of, we had about 800 respondents. The majority of gastroenterologists that responded were male. Women had less years in practice. There was slightly more men in a full-time practice. What's very interesting, and we also found from data that we published years and years ago about the gender disparity in salary in gastroenterologists, is that the majority of women were in an academic or VA type of position, because I think that supports you and buffets you to have that multi-specialty group. And it was also interesting back then that when we surveyed women over time, that women oftentimes stayed in their practice for a longer duration of time than the med did. They bounced around a little bit. But unfortunately, back then, we found that even when adjusted for all practice-related factors, women in gastroenterology got paid 30% less on the dollar than men, even with all the adjustments made, and that still holds true today. You can also see that women are most often salary, and other differences in the practice. So doing 2 hours or more of administrative time in the workplace. So you're done with your clinic schedule, you're looking forward to going home, and then 2 additional hours spent either in the workplace or taking clinical work home to get it done. More women do that. Spending more than 8 hours in an outpatient clinic area. So when people say, oh, well, how many patients should I be seeing a day? We can talk about that. But in the majority of our respondents, nearly 65% said they're spending at least 8 hours seeing outpatients per day. When they're on the inpatient service, they're doing 6 or more consults per day. And then when they looked at individuals that took more than 20 days or more of vacation, you can see that people are offered that, and about 55 to 65% of individuals actually took 20 days of vacation. And then you can take a look again that about half of the individuals were responsible to taking call 10 or more times per year for emergency procedures in the evening, at night. Okay, so what about lifestyle factors in this national survey? Some of the sad truth that male gastroenterologists are more often married than females. Maybe that's not the sad truth. Maybe that, people are choosing not to have partners. What's really shocking and eye-opening, and was also found in the general surgery burnout survey, that when you look at satisfaction with relationships, you can see that people were either meh about the relationship with their partner or dissatisfied with their partner, men 16% of the time, and women almost 1 in 5 were like, yeah, with my partner, or dissatisfied with their relationship. You can see that women are doing much more of the domestic chores at home, as well as in childcare. In this particular analysis, Joe broke down the hours per week on childcare by 10 hours. But when we look at things associated with burnout, you can see that women were doing more of the childcare as well as domestic duties at home that was correlated with burnout. More male physicians have a partner at home that is not working, so maybe more support at home. And then also it showed that women were more often childless and had younger children. The youngest age of the youngest child and the youngest age of the oldest child were younger. And that was oftentimes in females, maybe because they were younger overall. So what did we find about burnout? So 50% of the respondents that filled out all of the MBI, the Maslach Burnout Inventory Scale, had burnout. And it was based on emotional exhaustion and depersonalization. Most of the studies, if you read them, don't use the low sense of personal accomplishment in the burnout scale. So we modeled ours after the Shanafelt studies, but clearly 50% of gastroenterologists that responded, which may be a biased group, reported burnout. So what are the factors associated with burnout? Younger age, female gender, fewer years in practice, no difference between full versus part-time, people that said that they didn't find the electronic health record friendly, had higher rates of burnout, people that are spending more hours doing administrative or clerical work after the end of their workday. So you can see the workload, and many of these are associated with it. I'm an advocate for wellness and health, exercise, sleep, and making sure that you're eating proper nutrition, but also that you're actually getting nutrition during the day. And you can see there when individuals reported that they were able to eat lunch more than 50% of the day, they had less rates of burnout. So I think that just shows that people that, are working through their lunch hour and rushing to the office in the morning and aren't eating breakfast are just, they're burning it at both ends. People that are not taking as much vacation. And then when you look at people that are that report that they're not satisfied with their relationships, those individuals tended to be more burned out, again, which was the chicken and the egg. And then for the people that are doing the domestic chores at home, you can see that doing more work once you get home from work at home is associated as well. And then again, as I mentioned before, if your spouse is unemployed, working, they don't have a job outside the home, they said unemployed. I think that just speaks to more support at home, because those physicians reported less burnout. And then certainly having younger children in the home is associated, probably because all of the things that go along with it. And in fact, this survey was before COVID. So the impact of COVID may be positively or negatively associated with it, because we all have made changes in our workflow, doing virtual visits from home potentially. And that may give people the liberty to, watch their kids, to be home when their kids are sent home from school because they've been exposed to someone with COVID or they've had COVID themselves. So I think more data will come out, and the data on COVID and burnout is controversial. Okay, so what are the organizational drivers of burnout? Because when you look at the data, it suggests that, yes, you can do things, but really the most impactful alterations that can drive down burnout in the workplace is related to your organization. So, having excessive workloads, inefficient work processes, having the physicians working, below their top of license, where they're putting in orders, where they're abstracting records, where they're, doing faxing, using an electronic medical health record that is not efficient, and particularly when you have lack of input or control on your practice issues. So, during COVID, when most of practices were taking a downturn in reimbursement, we were advised that we needed to see 10 patients in a half-day session. And, if you're seeing IBD patients, you're seeing, complex liver patients, 10 patients in a half-day session can really be problematic. So we actually worked with the administration and said, listen, I can't see 10 patients in a half a day. I'm not finishing those visits until 2 o'clock in the afternoon. I don't finish my charting until 8 o'clock at night. And so we created a system where we said, hey, listen, I can do 6 visits in a half-day session, and then I'm going to do 1 at a lunch hour. I might do a few in the evening. And so I got my 10 patients in at a schedule that was, more workable for me. So I think having a practice where people give you the tools that you need to create the work processes to meet the goals of the practice as well as your personal goals. And then, as I talked about the importance in practices, when your leadership has a misalignment between what they want from the providers and what you want from the leadership, it's bad news all around. So being a voice and speaking up, leaning in and helping recognize opportunities and systems for change is really important. Okay, I'm not sure how many women are on the line, but gender consideration. So there are data that show that patients have better outcomes from female providers, and you probably saw that in JAMA a few years ago. But when it relates to some of these burnout issues, female physicians have more female patients than male physicians, And patient expectations differ between female and male patients, where female patients, want the woman that's really empathic, is going to listen. They oftentimes have longer visits. And oftentimes it's the functional bowel disorders, which can be, a little bit more time intensive. And gender differences in patients and expectations of female physicians can contribute to some of the burnout. So I have some ideas about if you are seeing a lot and doing female colonoscopies, seeing a lot of females in your practice, some strategies for that. Okay, so what might be some of the strategies that you might want to consider to enhance your efficiency in the workplace and get you home to or wherever you want to go in a more efficient time? So, COVID is no surprise. This was all before the COVID era, but virtual visits we've all gone to. And basically, my whole clinic is virtual visits unless someone actually has a physical finding that I need to document or I'm doing endoscopy. Another one is flex hours. I am a part-timer, but I have the ability to alter my clinic. So, if I have something to do, take my child to a play or go to a sports event. I'm not going to work on Wednesday morning and I will work on Wednesday afternoon, or I will work on Wednesday evening. So having the ability to flex your hours is also very important. Medical scribes, we offered them at the Cleveland Clinic. And at first I was interested. And the deal with the medical scribe is you have to pay for them. And when you had a medical scribe, they actually wanted to double the number of patients that you were seeing. So I said, no, I'm good with, with my current schedule. So I chose not to use a medical scribe, and I wasn't efficient when I tried it. But if you are efficient with it, it can really make a difference in your practice. And I'll show you some data on that. And then getting a coach. So if you are not able to meet the goals that you set for yourself, having a coach, different than a mentor and different than an ally. So a coach, and we'll talk a little bit about that, could be very useful for you. And then the last thing that we're effective and have many, over 100, these types of visits, they're called shared medical appointments, where you have individuals, patients that have like diseases, which could be eosinophilic esophagitis, or it could be IBS, or it could be hepatitis C, or non-alcoholic fatty liver disease, where they come in. And of course, this was before the COVID era. They all signed HIPAA consents. And basically, you could talk to, address questions to, and bill for almost a level 4 or 5 visit. And you need to have kind of a navigator and a facilitator. And I'll talk to you a little bit about that. So it's another cool way where in an hour and a half, you might be able to see 5 or 7 patients if you're saying the same thing over and over and over again. Okay, so the shared medical appointments, what are the nuts and bolts? Well, you need to have a knowledgeable scheduling staff. You need to have a room to accommodate, as many people as you can. And instead of patients checking in at the front desk and then sitting in the lobby and then going into an exam room, they actually just go to the conference room where they're sitting around and there's this group of other people. It's a 90-minute slot, and then there's a facilitator. So if I'm doing hereditary colon cancer, maybe the genetic counselor is there talking about what is a gene and what is germline testing and what does the implication of a pathogenic variant mean for you and your family. So you wouldn't want to have breast cancer patients and colon cancer patients and pancreatic cancer necessarily, but you can envision that if it's EOE or Barrett's esophagus, that it might work. And it could be a nutritionist. So they facilitate, and as patients are walking in, the medical assistant is getting basically their H&P and vital signs. The facilitator is saying, Mary Jo, what is your question about EOE for Dr. Burke? And Mr. Jones, what is your question about Dr. Burke about eosinophilic esophagitis? So when the physician comes into the room, after all the kind of basics are done and some education is given, then you can pull people out for a brief physical exam if necessary, or answer all the questions. So it's really cool. And we've shown that both provider satisfaction and patient satisfaction and disease control, because we have these in diabetes and asthma, is improved. So who are the good physician candidates? If you are heavily booked and you call and say, oh, I want to get in with Burke, they're going to say, oh, okay, she's available in 6 months, but her shared medical appointment is available in 2 weeks. So patients might say, I like that. And then oftentimes they meet a cohort of people and they learn things when other patients are talking about their medical disease management, and they oftentimes stay in the same cohort, and especially good for providers that are saying the same thing over and over again. Medical scribes, reduces your time in clinic potentially by reducing your time in the EMR. And also, if they're doing more of the documentation, then you're doing less after hours work. It's been shown to increase productivity, and it improves revenue independent of your productivity, because the scribes oftentimes are getting more comprehensive stuff into the note so that you're billing at a higher level. And there's the data that shows that physician satisfaction is increased, and oftentimes workflow in the clinic is increased. And then, clinicians said they preferred having a scribe and they felt more effective. I don't need to go over this. We're all doing telemedicine and virtual visits, which I love. Okay, so personal approaches to burnout. First, recognize that it occurs. I'll never forget, one of our fellows was not doing very well. They examined a patient and did an H&P in clinic with me, and they weren't hitting all the high notes like they usually do. And so we were debriefing, and I said, "Is everything okay?" He said, I can't think. I don't want to see one more patient." And I said, "Are you burned out?" And he sat back in his chair and said, "I've never thought about burnout." Yes, I think I am. So he didn't even recognize what he was feeling that, was wearing on him. And he was, becoming cynical and depersonalized. And when I gave it a name, it really struck a chord. It's important to prioritize, as I said before, your goals and what you want to achieve and where you derive your highest enjoyment, both in the workplace as well as at home. It's important to keep yourself in good health, so healthy behaviors, because burnout has been associated with mental health disorders, suicide, alcoholism, divorce, malpractice cases. So make sure that you're eating well, you give yourself time to take a break at your lunch. Don't sit at your desk and answer patient phone calls and eat right there, but really give yourself a mind break. I've given you some strategies to consider other options within your practice. For women that are seeing a lot of females and patients that are taking a lot of time, or if you're doing a disproportionate amount of female colonoscopies, which are more difficult than male colonoscopies, work with your leadership to say, "Hey, listen, I'm providing this really important service. Women are the ones that are bringing other patients in, their family members in. I need more time." And we can talk about, what that block should look like for a female colonoscopy. An important thing that's been associated with a substantial decrease in burnout is, we all have to work, right? We have to contribute in some way. And if you can get your leadership to provide you the opportunity to gauge in 20% of your work, so for those that are full-time, 1 day a week, and what you like to do, that would be great. For me, I want to see all the hereditary colon cancer patients there are. Someone else might want to do all of the quality-related work in the department. Someone else might, have research funding. So that 20% rule is really important. Chris Sorowitz is a mentor of mine. She was a past president of the American College of Gastroenterology. And she said, "I never go back to work after I travel." So how many of us, come back from DDW, we get back at 11 o'clock at night and we go back to work the next day? Take the day off after you travel. And then the other thing is to really be mindful. We are so lucky to be physicians in gastroenterology. We have a great job. We have a great profession. We have a lot of opportunities for networking. So, give gratitude where you can, because it has been associated with decreased burnout. And as I showed you some of that data, enhanced quality of life when you can find the meaning in your work and have a positive outlook and give gratitude. Okay, so some things that I want to, this is the intersectionality about things that can basically sabotage your career or make you burned out. So I don't know who's online, but you can be an ally for people. So I want to talk about allyship and being an ally. So being an ally is using your power, position, or privilege to uplift others, and it's an active state of partnership. So it can be anyone. Anyone can be an ally, any race, any age, any gender identity, function in the leadership scheme. And it's typically someone that has a status that enables their actions to be impactful. So, I am an ally, and so who I'm talking about that could have this ability to influence other people. oftentimes, being an ally, it's advocating for someone that isn't of your ethnicity, gender, sexual identity. So I have some examples who could be a good ally: men to women, or men or women into non-binary folks, cisgender people to transgender coworkers, white employees to people of color, senior leaders to lower level employees. And as I said before, the most effective allies are those that hold positions of power where their words are listened to, they're able to influence other people, and because of their stature, people will listen to them. Also, when people are in that position to be an ally, for me, I said, you know what, I'm taking this on because I've been in practice 30 years. I don't care. If they want to fire me, let them fire me, but people want to listen. So people that are in positions of power can be very impactful allies. And for most of us that can be an ally, as I said, we're unlikely to face personal consequences for speaking up. I was the former vice chair of the department. My institute head wants to hear from me. And if I have comments to make about people, they oftentimes listen. So allyship is really important, and I would encourage all of you to consider it. And you don't have to be a senior leader, but you can be a leader within your group, an ally for other people. Okay, so an ally is different than mentorship, right? Mentorship is someone that gives you advice. They can help shape your career. They tell you how they did it. And it can either be personal or a professional mentor. And basically, they are helping you on your career, giving you knowledge. And they can also talk to you about the hidden curriculum, how to negotiate things, how to be politically correct, some things that aren't written. And they also times give emotional support and encouragement. It's important that you realize that it's a two-way relationship, because I'll have people that'll be in a program and say, hi, I'm your mentee, and I'm wondering if you could write me a letter for, an advanced endoscopy fellowship at the Cleveland Clinic. So being a mentee and being a mentor really is a relationship that's built on mutual understanding, support for one another, and understanding the goals of how this relationship will work. And some of my most memorable relationships have been with my internal medicine residents that now are, assistant, associate, and full professors in other departments, even, in family medicine or oncology. So keeping that relationship is very important. It deepens it, and it also is very helpful for the mentee. So different than an ally and having allyship and a mentor is a coach. And a coach, I went through the advanced peer coaching training at the Cleveland Clinic. And it's a very interesting process where the coach doesn't provide advice to you. And the best example I can give is it's just opening your eyes to help you discover what you need to do to get to the place that you want to get to. So for example, if your kid says, oh, mom, I'm hungry, instead of saying, oh, honey, what can you, what do you want to eat? I'll bring it to you. The line of question could be, oh, honey, I hear you're hungry. What could you do about that? Well, I could go to the refrigerator. Yeah, and then what might you get? Well, I think I want peanut butter and jelly. Well, where's the peanut butter? Where's the jelly? So, you want to train for a marathon, and your coach. So you go to the coach and say, what? What are your goals? I want to train for a marathon, and I want to run it in 6 months. And the coach isn't going to tell you what they did to run the marathon. They're going to say, well, what are the things that you need to do to be able to run the marathon? Well, I need to buy a pair of tennis shoes, I guess. I need to, start a training program. Well, where do you find a training program? Well, there's these apps online that are available, and, the gym has, a running club. Well, could you join XYZ? So in the workplace, it's a little bit different, where people need a coach because maybe they're having trouble with the administration getting something that they need in the workplace. Maybe they're not advancing in their academic career. Maybe they're having problems with some colleagues in the workplace. So A coach can be very helpful. It's not giving advice. It's helping you realize where you want to get to and having you open your own eyes to the tools that will get you to where you want to go. Oftentimes, this is more prescribed in that, okay, well, so here's the things that I heard you say today, we're going to work on in 3 weeks. We'll meet again and you can let me know which of these 3 goals that you've met, and then we'll continue this relationship. So it's not kind of a warm and fuzzy thing, but it's someone that's enhancing you to get to where you want to go. Okay, a thing that I learned late, but it's really important, as a woman, or, maybe many people, I feel like I'm doing so much stuff that everyone knows what I'm doing. But in fact, your chairman or your boss has no idea what you're doing because they're very busy. So it's really important for you to manage up. So, when you get the next award, when you get the next oral presentation, when a patient sends you a letter about how impactful you've, made their disease burden improve, whatever it is, manage up. Let your chairman, let your boss knowing all of the good things that you're doing, the program that you're starting, anything. So manage up. That's really important because if you don't tell them, they don't know. Networking. I have very little burnout because I love what I do. Being involved in national societies, being on, the U.S. Multi-Society Task Force, being a member of the National Comprehensive Cancer Network, working on other initiatives, in my church, in my community. The more people that you meet, and using social media, which I don't use, the more people that you meet and you're building these networks, the more happy you'll be in your work and in your personal life. So building networks gets people to recognize who you are. And when it comes to, hey, we're looking for someone in XYZ position or someone that might have advice, they're calling you. They're saying, hey, listen, we brought your name up because we know that you're really good at this. And this other person, has an opportunity. So don't forget managing up and networking. Okay, last couple of slides. I want to leave lots of time for questions, and I just might stop for a minute. I see that there's 4 questions in the chat. So if Holly wants to stop me at any time, please do.
Would you like to take a couple questions right now?
Sure.
Okay. So the first question that came in is, what is the average number of patients a GI provider should see in the clinical setting every day to have work-life balance?
That is a great question that doesn't have a direct answer. So as I mentioned before, we were told that we needed to see 10 patients in a half day. Half day starts at 8 and ends at noon. So basically, and these are new patients, so roughly every 30 minutes. And so there is no right answer to that. Some people might be working with scribes or working with an NP or working with an LPN that is with you shoulder to shoulder in the clinic. So you're very efficient. So I can't really say what it is, but I would say that if you feel like you are not providing quality care to a patient, having high quality documentation of what you're doing, and you're feeling burned out, that's too much, right? Lawsuits would be another thing. If you've missed important results to return to a patient, if you're not closing your charts, if you're not being able to accomplish the duties that are required in your position, that's certainly a sign. But there is no right or wrong. I interviewed at a place many years ago and they said, oh, we're working so hard, we see 6 patients in a half day. I said, oh, that's like heaven, right? So it varies according to the practice. I think it varies according to the specialty that you're in. And so there is no right answer, but it's all of those other things that are signals that you may be working too hard or too fast if you're not providing high quality care.
Excellent. Thank you. And so I'm going to wrap 2 questions kind of together because I think they're very similar. So one question is, my compensation is based on WRVU and does not reflect the fact that most of my patients are female, more time consuming visits and more difficult procedures. So what strategy should I use with my leadership to recognize my contribution? And so this also wraps into a previous one that's asking about time blocking for female colonoscopy. So I guess kind of getting into that, how do you manage time and that expectation?
Yeah, great. So managing up is really important. And so getting data about the proportion. And so we have a women's leadership council now at the Cleveland Clinic. Miguel Reguero, a gastroenterologist, is the institute chair. He was my department chair. He still is. And he's gone up to run the Digestive Disease Institute. And so he put this council together to address some of these issues because a lot of practices have problems recruiting or retaining women. And so we are getting the data looking at the proportion of referrals that come into the practice to women providers. We're looking at the proportion of surgeries that are done on women by female surgeons. We're looking at the proportion of colonoscopies done by female gastroenterologists or colorectal surgeons in the practice. So I'd say getting data is important. Sharing the evidence that women's colonoscopies are more challenging, they take longer, would also be fuel to fire. And then the other evidence that, for every women that you bring into a practice, there are probably associated referrals, including men in the practice. So I think creating an evidence base to go to the leadership to say, hey, look at this disparity between potentially providers, male and female providers, providing the evidence that, and there's evidence in the literature about, women's colonoscopies are more difficult, they're more challenging, their colons are longer, and the time it takes to do their colonoscopies is longer. And then there are the data that talk about, that I've provided you some references for, about women in the clinic. So I think using an evidence-based approach is the best, but also managing up what you bring to the practice. And, for years, now, every time I go to a meeting, people are saying, do you have a female fellow that wants a job, right? Every practice wants a woman because they bring in many more patients. So I would use the evidence, and then and then also what your value added to the group is. In terms of time blocking, I used to do all my procedures in 30-minute slots. And so I do a lot of polyposis, so, and CDH1 gastric cancer surveillance. So, I'm removing 50, I have a lot of polyps. So I was able to move all of my procedure slots to 45 minutes. And also I've been in practice for 30 years. So my RVUs are much higher than the rest of my partners, probably because I'm in the general GI group. But my procedure slots are 45 minutes. I also get referred people that had incomplete colonoscopies. So I think showing, what I bring to the department is helpful. But for me, I'm on 45-minute exams. And I don't know what, most people, most of our practice is either 30 minutes or 45 minutes.
Great. And then any advice for women GI entering a community practice with a partnership track? No boss, but overhead responsibility frequently requires higher productivity.
Okay, so Holly, I'm not sure I got the last part of the question.
Sure. So I think the primary question is any advice for women GI entering a community practice with a partnership track. And so then there's a comment that says there's no boss, but overhead responsibility frequently requires higher productivity.
Right. So there are ample, community practices, and I presume this is private practice, could be a community practice with an academic medical center, but when you're looking for a job, you should be looking at the books, right? So you should know what the balance sheet looks like for the practice. Look at the balance sheet for the individual providers. If they say, oh, we have this multi-specialty group and we have, something in Highland Heights and we have something in Shaker Heights and we have something in downtown Cleveland and somewhere else, that if you are part of the group that's going maybe to an area that has more Medicaid patients, right? They may say, oh, here's the books, but you need to know that, that there is parity at some level between where you're providing care, because people might cherry pick, like the senior practice people are, in the more affluent area where there's good reimbursement, and you might be stuck in a practice where there's, more self-pay or Medicaid. So I think looking at the books, talking to the practice about that. Partnerships are good, and this should be all laid out in your contract before you join the practice. And I'm not sure what it means about no boss, but everyone needs to generate above and beyond their RVU targets to cover the infrastructure or overhead. So it's all about knowing the financial obligations of the group, the practice, the payer mix that's within the practice or at your site, and then negotiating for it. And again, this all starts early on, like, don't join the practice where you don't feel comfortable with that. And I'm not sure I answered your question, but those are some of the things that I can think of.
Great. And we just have one more, and then we can move on through the rest of the presentation. So the last question is, what is the average number of minutes spent with new patients for pre-colonoscopy or pre-endoscopy?
Yes, it's only getting longer. So now we were just told that we need to do we have to fill out a comprehensive history and physical. It should be done within 30 days of the procedure. And if it's not done, then we need to do that right before the procedure. So, we have a lot, we all have a lot of checklists. So meeting the patient and that. So on Sunday, I need to review the patient's chart. I need to actually put in the pre-procedure order. So I'm ordering the IV fluid, the IV insertion. I'm ordering Fleet's enemas if they're having sigmoidoscopies. So I have to put those orders in ahead of time. And then I'm, writing on Sunday night for my Monday morning procedures, the name of the patient, their drug allergies, who their contact person is. So I'm writing this all down. So when I go in to see Mrs. Jones, I'm like, hey, Mrs. Jones, how's it going? Is John driving you home today? And, happy birthday, because I can see that. So I do a little bit of small talk, but I do the pre-work beforehand. So I spend, because, I'll do 16 procedures on a day potentially, that I spend at least an hour the day before, putting the orders in and kind of reviewing their chart. So I'm up to date on who they are and what I'm doing for them. And when I'm in the endoscopy suite, then it has to be the time out. So, okay, we all have to do the time out, and there's a checklist that the nurses need to do. And then I have to do the pre-procedure assessment, which is kind of the pre-anesthesia assessment, because most of my practice is conscious sedation. And then it's this more comprehensive H&P, which, is going to be not very comprehensive, but I know enough about a patient that I could know about anticoagulant use. So I would say that I'm spending at least 10 minutes prior to being able to have the patient sedated. And as I said, I'm lucky enough to have 45-minute procedure slots. But, if it takes 10 minutes to do that and it takes 7 minutes to get them sedated, then basically it's 30 minutes to perform the procedure. And if your withdrawal time is 15 minutes, and your insertion time is 10 minutes, then, 45 minutes is, I'm right at my hilt. So I would say for us, it's about 15 minutes, but with all the regulations, it's just getting longer and longer.
Excellent. Thank you. And we have about 5 more minutes if you want to finish up, and then we can address any additional questions that come in.
Yeah, great. Okay, excellent. So imposter phenomenon, imposter syndrome. I just want a few words about that, and then microaggressions in the workplace. So imposter phenomenon was it's a syndrome originally as described by Dr. Suzanne Imes and Pauline Rose Clance, and I just communicated with her because I'm giving a talk at Scrubs and Heels in Miami next week if any of you are going, and they assigned me this talk on imposter phenomenon and microaggressions. But basically, it's a phenomenon that I've experienced, it oftentimes seen in high achievers who attribute their accomplishments to luck or, oh, it's my mentor. I owe it to God. I owe it to everyone, but God is important. But you owe it to, you owe your success to everyone but yourself. So, and then, most of the women that were presidents of the societies that were mentioned in 2017 or whatever, I had to pinch myself, like, why me? Like, when are they going to find out that I don't really deserve this? I mean, what did I do to deserve it? So it's also that thought, like, oh my gosh, they're going to uncover me that I'm not really as smart as they think I am, or, organized or whatever. So I wish I could see your faces to know if you're all nodding out there. So why should we care about imposter syndrome? Because it affects, high achievers, women, underrepresented racial, ethnic, and religious minorities. It's very common in medicine. It leads to burnout, stress, anxiety, depression, drug abuse. And it starts early on, as early as high school. And if we're constantly downplaying our personal accomplishments, we're not managing up like, hey, look what I'm doing now. It may sabotage our career. And when it starts very early as high school, then it can impact our pipeline to women in medicine and, and the STEM. And it certainly threatens diversity. The fuel for imposter phenomenon is, feeling different from the majority of your peers, whether it's race, gender, sexual orientation, or age. It oftentimes happens when you're starting a career, like, oh, I don't really know anything. When you're asked to take on a chairmanship or leadership role, something that you don't feel completely comfortable in. And it can lead to systemic oppression. So oftentimes seen in people that have always been pressured to overachieve, like, medical students. And oftentimes, you're criticized when you don't feel like you're number one. And so it's quite common. And I have some data here that says, imposter phenomena was seen in, 44% of men and 56% of women that are third-year medical students, mostly a white cohort, in general surgery residents, looking at 6 different programs. Significant or severe imposter phenomena was reported in 76%, no difference with gender, ethnicity, PGY level, or exam scores. When they looked at about 270 Canadian residents in a variety of different programs, imposter syndrome phenomena was seen in 63% of the cohort, higher in females, 30% greater than males, and was associated with levels of anxiety and burnout. And then when they were looking at radiology faculty, imposter phenomena was reported by 83% of the radiology faculty, and 84% said, it began as early as medical school. So quite common and can be a career buster. How to combat that? Normalize the feelings of imposter syndrome. Don't feel like you're alone. Talk about it. Foster a community of diversity and inclusivity, and then challenge your negative self-talk. When you're successful, when you get an award, when you have an accomplishment, it's all because of you. It's because of your hard work. It's because of your knowledge. Let people know. So, make sure people recognize that. Again, develop a supportive network of allies. So if you have negative self-talk, you're just not feeling confident, talk to others and say, I just want to check in. What do you think? And, you're going to be surprised of, how much positive reinforcement you're going to get. Dismiss the need to be a perfectionist. Don't ever write a paper with me. The fellows did a journal club, and we spent 3 hours because I wanted to be a perfectionist. Don't send the paper till I look at it for the 7th time. Finally, I say, just get the draft off, like let it go, and then see what happens to it. And then be an advocate for other people that feel like imposter syndrome, to empower them to recognize it and try to work through it. So microaggression, last few minutes. It was a term, so imposter phenomena was coined by psychologists. Microaggression was a term coined by a psychiatrist who was a Harvard professor, very accomplished, African-American, and it's where statements and actions are directed to usually non-dominant groups that reinforce stereotypes, and it's an attempt to affirm the attacker, I hate to use that word, but to affirm notions of someone's second-class status in society. And I'm sure we've all been part of it, where you feel like you're invisible in a group, where you've mentioned something and completely dismissed until the guy in the group says something and they're like, oh yeah, Joe, right, that's a great comment. And so I have some approaches to actually challenge that. Classically, it's been attributed to race, but it includes gender identity, immigration status, sexual orientation, disability, and other groups that are historically marginalized or vulnerable. It's linked, again, like burnout is, to depression, anxiety, hypertension, imposter syndrome, and really is another way that you can blunt your professional success. Let's see. How prevalent is it? 54% of US medical school students had experienced it, higher in females than males. In this particular population, there was very few, a smattering of other ethnicities, but mostly white. 70% of plastic surgery trainees experienced it within the last year. And then there was this very fascinating study that was in JAMA Surgery, and they looked at sexist, racial, and ethnic microaggression against female and racial and minority surgeons and anesthesiologists in a large HMO in California. They looked at different scales of microaggression, and suffice it to say that microaggression was reported in 94% of females and 81% in racial and ethnic minorities. And when they looked at the intersection between burnout and microaggression, they saw that burnout was higher in individuals, racial and ethnic minority females versus white males, 84% increase in burnout. White females versus white males, almost a twofold increase in burnout. When you looked at, and that's sexist microaggressions, when you looked at racial or ethnic microaggressions, you can see higher in racial and ethnic minority females versus white males, and racial and ethnic minority females versus white males with both sexist and racial microaggressions. And there's different types of microaggressions, microassaults and other things. But so if you're faced with microaggressions, someone, oh, I heard you got the job of chairman. I heard that they were, they wanted an African-American. So if you're part of a group hearing that, or if you're hearing that, you could say something like, I'm sorry, could you repeat that? I'm not sure I heard what you said. Or I heard you say blank. Can you explain what you meant by, oh, I heard they were wanted to hire a Black XYZ, or whatever it might be. Or I'm curious, I wanted to better understand why you said what you did. I'm not sure if you're aware, but this is how I'm receiving what you said or did. Was that your intention? I had one of my trainees that said she was on rounds, and the attending said, oh, your eyes are so emotional behind that mask. And she's like, what the hell is that? I'm on rounds. Or you can say, I believe a more inclusive term would be using X, or we don't tolerate that kind of language here. I would ask that we treat everyone with respect. So, I've just provided a variety of statements that you guys could think about and use in a situation, either if you're the focus of the microaggression, or if you can be an ally or in a group where you can speak up to the defense of someone else. And if you don't have the courage to say it in the group setting when it occurs, be sure you reach out to the individual and say, hey, listen, that was really terrible. I'm sorry, I'm here for you. But it would be great if we could all as a group make sure that this is at top of mind and we call it out at the time. So combating these two things in practice, increase awareness and visibility of these issues. In the practice, and the group set metrics, measure the prevalence of these, and provide interventions and remeasure to see if strategies are working. Develop educational programs about this, because some people are like, oh, we knew what happened with Black Lives Matter. Oh, all lives matter. Well, you're missing the point. Black Lives Matter. And to say, oh, well, I don't see color in the world. Well, we do need to address it because there is color in the world, right? So we need to be an advocate. So creating organizational policies, which can include coaching, peer mentoring, support groups, training local leaders and champions, and then highlight successes in your group. So I've talked a lot, and I'd like to stop there and open it for questions. So thanks for your time and your attention. And I really hope this has been of value to you.
Thank you so much, Dr. Burke. I think we're about out of time, but I think there's one question that could be really good to kind of wrap everything up with. And so the question is, in the 30 years of your practice, what is the first thing that comes to your mind that helped you recognize and rapidly mitigate burnout?
For me, it was making my priority my kids, and so never going full time. And so if you're thinking about part-time, I think the most important thing, so your leadership doesn't look at you crosswise, is make sure when you meet a patient, you say, hey, I'm a really great doctor, but I'm only here 3 days a week. And so, if you have an emergency, I have colleagues that will support your needs and nurses, but I may not be available for you for 4 days. So just making sure that if you are choosing an alternative path in your practice, which includes part-time, that you get your partner engagement, you get the leadership engagement as how you're going to provide quality care, and that your patients know, because there's nothing worse than a patient saying, oh, I went to Dr. Burke and she never returns my phone calls. But if you set expectations up front, your patient will continue to love you because you're a great doc.
Excellent. Thank you so much. And thank you for your time. I hope everyone, I know I learned a lot from this presentation, and I look forward to seeing kind of what the feedback was. So thank you again for your time, and everyone have a wonderful night. Actually, in the chat, you can see there's an evaluation that Marcia so wonderfully put in there. So if you have a moment to please fill out the evaluation, that would be great to help us improve and create really great content for you in the coming months. So thank you again. Yes, Dr.
Yeah, and Holly, I have my email there. So if there's questions that we didn't address, please feel free to email me, and I'm always available.
Excellent. Thank you so much. And everyone have a wonderful evening.
Good night.
Good night now.